Thank you, Francesco, for coming to Spain and joining in our national congress. It's our pleasure to have you with us. So let me ask you, you've chaired the last guidelines on diabetes. What are the key points that every cardiologist should know about managing patients with cardiovascular disease and diabetes?
Well, thank you, Héctor, for inviting me here and for discussing this issue with you today. I think the most important is that in the last 10 years or so, we have achieved so many new evidence based on the results of the most recent cardiovascular outcome trials, which are changing our way to approach diabetes. I mean, for the first time, we have pharmacological tools which by controlling glucose levels have an impact on cardiovascular events, major impact, reducing MACE, reducing hospitalization for heart failure, reducing the progression of kidney disease. So we have really strong new drugs which are able to do all this. Mm-hmm. And this is for the first time ever.
Mm-hmm. So you actually changed a little bit the paradigm, a bit in parallel like the heart failure guidelines, which changed the use step-by-step approach to say, I mean, there's 4 key treatments that should be used. Now diabetes, you have changed this initial paradigm of metformin and so on. Now
Definitely.
We have new drugs that actually can be used in the first. How should cardiologists use those options?
I mean, yes, we were able, based again on this evidence, to make a major shift in the algorithm, mm-hmm. treatment algorithm. Traditionally, first-line agent has been always metformin, but now in patients with diabetes and very high cardiovascular risk, the first-line agent are either SGLT2 inhibitors or GLP-1 receptor agonists. And this is really important to ask ourselves when we see a patient, is this a patient with diabetes and established cardiovascular disease, or is a patient with very high risk for cardiovascular disease? Then we should start right away with either of these drugs.
So would you recommend to use SGLT2 inhibitors for heart failure or higher risk of heart failure, and LGP receptor agonists for more, let's say, arterial thrombotic risk, or it doesn't matter? What?
No, I think this is what the results of the trials are telling us, mm-hmm. that the SGLT2 inhibitors, because of their mechanism of action, may be more appropriate when we want to fight the heart failure mm-hmm. setting or declining kidney function. Whereas the GLP-1 receptor agonists have a very pronounced anti-atherosclerotic effect. And then the combination of the two, it's a new frontier in a way, mm-hmm. because mm-hmm. we could have an additive effect by combining the two, although we do not have trials
exactly.
With a combination yet. So that's another issue.
But actually we're moving forward a little bit the concept, because now is not anymore treatment for diabetes only. Now as LGT2 inhibitors are not even recommended for non-diabetic patients.
Yes, indeed.
So it's a new mechanism of action rather than hypoglycemic drugs?
Definitely. They have a lot of a pleiotropic effect which goes beyond the glucose control. Mm-hmm. And we know the evidence from the last heart failure trials, which were performing patients not only with diabetes, but also without. They have been showing that regardless of diabetes, they are able to reduce hospitalization for heart failure.
This is the Congress of Cardiovascular Health, so we really believe in a multidisciplinary approach. We think that health actually comes before any patient comes to cardiology. Do you think that still there's strong room for improvement in cooperation in the management of diabetic patients, in the decisions for this treatment with, let's say, diabetologists, endocrinologists, and other specialists who are involved in the management of these patients?
Definitely. I think glycemic control is an important part of the multifactorial management of patients with diabetes. And we know that glycemic control is important to control the microvascular complication. And so the only way to win the war against diabetes is to have a joint effort of multidisciplinary specialists. So we need to have across the specialty borders a strong collaboration with diabetologists, with the nephrologists, internal medicine colleagues, because only by joining forces we can really do the best for our patients.
Do you think that we're in a good situation in, I don't know, maybe in your countries, in other countries, in the hospitals and in primary care, in this cooperation, or do we have to be more proactive?
I think we need to be more proactive. I mean, it's easy to say that, but then there are a lot of barriers which has to be overcome. But I believe that if we really are aware of that and we believe in that, this can be easily done together with all the other stakeholders in a hospital organization and in each country.
So maybe the conclusion should be that we need to increase collaboration with all our colleagues managing these kind of patients and deciding how to use these drugs optimally in the specific patients.
Yes, indeed.
Okay, so thank you very much. It has been a pleasure and an honor to have you with us today.
Thank you, Hector.